The life packs are a bit faster. All right. But anyway, you want to have their name on it. The life packs will spit out a new 12 lead if it changes. The Zols do not. Okay? It's a good idea to take numerous 12 leads if your patient is actively having chest pain, because things change. In 10 minutes, you could have a completely different 12 lead. Okay? So you should do more than one and make sure there's no changes. Or if there is changes, sometimes you put somebody on oxygen and give them some nitro, and voila, their 12 lead looks better. Okay? Because that nitroglycerin has caused the coronary artery to open a little bit, so there's more blood flow, so there's probably less elevations going on. So that's a good thing, right? Until the nitroglycerin wears off. All right. Make sure the patient doesn't get chilled. Well, I'm more worried about do not do a 12 lead in the middle of the mall, okay? Especially if it's a female. It is, and you have to do it right then and there. Make sure that they're, covered and people cannot see everything. Okay? So you got to keep in mind patient modesty. Okay? All right. So this just tells you what area things are viewing, and this is my favorite poster because down here it's color coded, so 2,3 AVF is inferior, and then it shows you up here in green what part of the heart it's looking at. Okay, and V1, V2 is purple, so it'll show you the septal view somewhere on here. Oh, there it is, up there. Okay, so it'll show you the different arteries involved as well. Okay, so if you want to take a picture of that, feel free. But for me, it helps me visualize what I'm looking at and the arteries and stuff like that are involved. Do you absolutely have to know the arteries that are involved to do your job as a paramedic? No, but it doesn't hurt, and you have to know it for this class. Okay, because the more educated we are, the more we can have educated conversations with the doctors, and the more that we do that, the more that they will respect us. Okay, which is ultimately what we want. All right, so here's another picture of all the different things, the different directions that we're looking at. Okay. All right, so this is pretty much the same as that, except you don't have the pictures on the heart. Okay. But it does tell you which artery it's looking at. Okay. So notice 1 AVL, V5, and V6. All right. So that's the left circumflex in most people. All right. And that is the lateral wall of the heart. Sometimes you get V1 through V6 that are elevated. Do you think that's a good thing? Because that means there's more than, basically the LAD is probably occluded way high up, and it's cutting out the LAD and the left circumflex. So that's bad. Okay. And then we have our RCA, or our right coronary artery, that feeds the inferior wall, right? And what did we say about that last week in terms of what the right side needs to preload, right? So if you've got somebody with an inferior wall, you should probably hang a 1,000 bag just in case. Okay? And be careful, very careful with the nitroglycerin. Like, I will not give anybody nitro unless their systolic is like 160, because it's going to drop like a tank. Okay? They're going to go from like 160 to 120 systolic. So you want to have your fluid ready to go if that happens. All right. So when you're looking at the tracings, did all the leads print? Is there artifact? Try to do it when you're not moving. I try to usually do it in the patient's house because there's less interference. Okay. You don't want like road noise and bumps and all that other stuff, because then it's harder to read your 12 lead, right? You want to get the cleanest 12 lead that you can. All right. Now, if your monitor suddenly stops working, it happens sometimes. And you try to troubleshoot, and maybe sometimes you just need another monitor, okay? But turn it off, turn it on. Unplug it, plug it back in, the leads. Unplug the 12 leads, plug that back in. Happened to Rob and I the other day, okay? And I needed a 12 lead on my patient, who might have hantavirus, by the way, because, you know, why not? And anyway, we had to switch out monitors. But when I wrote it up, we also had the strip that showed that there were like lead fault in all 10 or all 12 views, okay? And I took pictures of that and attached it to the report, because you know why? When that thing fails on a cardiac arrest and Empress gets sued, all those things are discoverable. And I can show that I reported it with pictures. And they did nothing about it because, you know, that's what they do. So, cover your own butt at all times. The company will not cover your ass. I will tell you that from 30 years of experience. Okay? Always cover your own butt. All right. So, what are we doing? You already know we're going to be looking at the rate. Is it regular? Does it have all its parts, right? So same thing that we're doing, we're looking at dysrhythmias. Then we add in access. Why do we add in access? Does anybody know?
Tells us the direction of the electrical pathway.
Right, and that direction of the electrical pathway can tell us some things that might be wrong with our patient. Okay? So, this chart tells you positive and negative deflections. That's all lovely. Let me get to, okay, so here's the quadrant thing. So that picture, right? On your 12 leads, there are numbers. Many of them print out with numbers. So on the top of your 12 leads, whenever you print your 12 leads on a patient, it has numbers. The 3 numbers. Oh yeah. But no, there's another one that's. Anybody have a real like a 12 lead in their pocket from work?
Yeah.
I know somebody does.
This entire class should
See? I know you guys are right. All right. So it will tell you the axis. It'll tell you the P, the QRS, the T, and what you're looking at. Okay. So you're looking for the number, usually the QRS, 70 degrees. All right. So 70 degrees falls in, okay, normal. So this quadrant here, it goes from 0 to 90. So 70 degrees on the QRS falls in normal. Everybody see that?
Mhm.
Make sense?
Yes.
Okay. But let's say your number is negative 50. That would be up here in green. Okay? So negative 50, you would have a left axis deviation. And we'll talk in a little while, we'll talk about what kinds of things that can mean. Okay? But look around. Can I circle this?
Yeah.
On here? It prints out a little bit differently on the physio models, but it doesn't break it down like that. But the one that I circled shows you what the number for the axis is. In order for that number to be right, your stickers have to be on correctly, in the right place. All right. It is not common to have the yellow extreme left axis. That's bad, okay? That's like get your pads out and put them on your patient, bad, okay? And then right axis deviation, what do you think that might represent? What kinds of patients? affects the right side of the heart. Yes, people that have some pulmonary problems. Good. All right, so we'll talk more about that, but you'll see where that prints out. So you don't have to really like do anything fantastic about this. It'll give you the number, and then you can remember what is normal, what's not. Okay, so then we have the up, down, down. This is not the best. Let's look at. Oh, man, why does it do this to me? I don't understand. Does not like. I've been presenting. So, if you're looking at an EKG, and you look at this piece of paper, okay? If lead 1 is positive, and AVF is positive, then that's a normal axis. Okay? So that's pretty simple, right? If lead 1 is positive and AVF is negative, then you might have a left axis deviation. Lead 1 is negative and lead AVF is positive, then you have a right axis. Lead 1 is negative and AVF is negative, then you have the extreme left axis. So the bad one. Okay? So in addition to looking for the rhythm, the rate, and all those other things, you want to be thinking about axis and is their axis normal?
Can I ask what information do we glean from that? Like if we have like left axis deviation, what does that really mean?
Okay. So let's look at this here. Life in the Fast Lane is probably one of the best sites that you're going to find. All right, so let's talk about right axis deviation. It could be any of these things. Okay, so like we said, right side. So acute lung disease, chronic lung disease. So acute lung disease, an example is a pulmonary embolus. Okay. Hyperkalemia, sodium channel blocker toxicity. Anybody know a sodium channel blocker off the top of their head? There's one that we give. Right? Do you think somebody can get lidocaine toxicity because they get too much lidocaine injected into them when they're getting sutures? Yes. Okay. You're at particularly dangerous times of your life in the beginning of July. Why is that? New residents.
Murder month.
Yes. There are brand new graduated medical students in hospitals. Don't always have the best supervision, okay? They don't know what the hell they're doing yet, okay? They're a first-year resident. They're supposed to be working with a senior resident and an attendant, okay? But sometimes they get left alone. Go suture that. That should be easy for you to do. Third-year medical students do that, okay? But what if they give you too much lidocaine? You can have a sodium channel toxicity, okay? So that is just an example of how that can happen. And any place that has residents, seriously, July is not a good time to do that. You can have a posterior fascicular block, right ventricular hypertrophy. What does right ventricular hypertrophy mean? What does that mean about the right ventricle? It's bigger than it's supposed to be, right? Probably because of a chronic lung disease or a pulmonary embolism, okay? But if it's ongoing, that's probably a chronic lung disease like asthma or COPD. Okay? It could also mean they're having a lateral myocardial infarction. So, anybody remember where we're going to see that on our 12 lead? What leads?
2, 3.
Nope.
Lateral is 1, ABL, 5 and 6.
Yep. So 1, ABL, V5, V6 will have elevations. All right, it could also mean WPW. So that's our right axis deviation. Okay.
So would we look at like the shroud, see something there that causes us to think something's wrong and go to the axis deviation to confirm, or would we go the other way around?
Yeah, you would. So. Notice how they do that here, the up, down, down thing. All right, causes. You could have a left anterior fascicular block. So, where do you think that is? That block. It's in the ventricles, right, on the left side, right? Also in left bundle branch. Left ventricular hypertrophy, so chronic hypertension will give you that, okay? Or valvular disease, like an aortic stenosis, because your heart's pushing harder to get the blood out, okay? Because the valve is stenosed, right? It could also mean they're having an inferior MI. Also WPW, it depends on which side it's on, and a paced rhythm. Okay. So those are some of the causes. We are kind of handicapped in that we do not have access to their previous EKGs. So we don't know what is normal for these folks, unless we pick them up at the doctor's office and they happen to have the old one and the new one that they gave us. Okay. But for the most part, we don't know what their normal is. Sometimes their normal is pretty darn ugly. Okay? And we look at it and we're like, ah! But that's their normal. Okay? So, let's do alright, so questions about that? Okay. Alright, so the axis will always move towards hypertrophy and away from infarction. Okay, so think about that, because if you have an infarcted part of your heart, the electricity is not going to go through it really, right? Because the tissue is ischemic or injured already, right? If you have an enlarged ventricle, it's going to take more force to make that contract, so that there's greater electrical energy. That makes sense, right? All right, so here we have our bundle branch blocks, our conduction system disturbances. So there's a couple of different ways that people remember this. The turn signal thing is one way, right? Has everybody heard of that? But we're going to look at V1. Okay. So here's V1. What do you notice about this?
Look like a bird.
It looks like that bird picture, right? But there's kind of two R waves there, right? See that? And they're both upright. So that is a sign of a right bundle branch. You have R and R prime. That is two R waves. All right? You can also see S waves in 1 AVL and V6. So here we have an S wave here, there, okay? Here, down there, okay? So that will give you a hint. If you're not sure, then you can look in those other leads as well to see if you have S-waves. Okay? So, how many branches does the right side have? Remember? One. Okay, the left side has two, but the right side has one. Okay. So now, we have our left side. So V1 has this huge S wave. Okay. Do you think that's good? Not great, okay? You see R waves, big R waves, in 1, AVL, and 6. Okay. But you get a wide QRS kind of there, and up there. They're usually, usually looks wider and more bizarre than the right bundle. Sometimes the right bundle would be referred to as bunny ears because you have the R and the R prime. Okay? But this is your left one. So we're always looking at lead V1 to look at that. So this little guy here is like the R wave, and then that's the S. Notice how the T looks big. So the other day, Steve was talking about Scarbosa criteria to some of you. Okay, so basically, it's looking at is this 25% longer or taller than the S wave? If they have a left bundle, it could be because they're having an MI, or it could be because they always have a left bundle from previous MI or other heart damage. Okay, but like I said, we don't have a previous EKG, we don't know. But we treat it as an MI until proven otherwise. All right, so then there are blocks. Do you think it's good to have blocks in the fascicles, in the ventricles? Yeah. Not really. Do you think having more than one is worse than just having one? Yes. Okay. So if you have one, it's a fascicular block. If you have two, you have a bifascicular block. If you have three, it's a trifascicular block, and you better be putting pens on your patient. Okay? Because they're going to code. Right? So, this tells you, I think I just said that. Okay. And it doesn't really, we'll find some examples of blocks for it. Okay. All right. So, other things that can happen. That delta wave. Okay, it's like that sloping upwards of that R wave. That tells you that they have WPW. Really? I don't understand. It does not like it. Yeah, keep playing. Okay. So, if you look through the 12 leads that I gave you, there should be one that has a delta wave. It is the one that says 6/11/25, 4:14 p.m. in the top left. Type A WPW, it says on the top. Okay? Look at lead V1 in that. Do you see that sloping upwards of the R wave?
414.
Yes. Yeah. 6/11/25, 4:14 p.m. And in the middle it says type A WPW, ECG. Okay, this one. It's in your handouts. Let me know when you've found it. All right, so does everybody see the upward sloping in V1? Okay, you can see it in other leads too, but in general, you're going to look at V1. Okay, so this person has WPW and has a pre-excitation syndrome, basically. Okay, so if this happens too quickly and their heart rate speeds up too much, they can go into cardiac arrest. Okay, depends. There are different types of WPW. Some are more dangerous than others, but most of the time they get them ablated in the lab. Okay, especially if it's one that's super fast and from a certain site with a certain pathway, they will ablate them. Okay? And like I said, it's usually found by accident. But if somebody doesn't know they have it, and they like are, chugging monsters, you think that's going to work well for them? No, that's the kid that you're going to get the call for in the nurse's office that's super dizzy, right? Or feels like their heart's beating out of their chest, right? So that is not a good mixture for them because they already have this problem with this pre-excitation and WPW. It's just going to make it a lot worse. You don't need to know that other syndrome. Okay. So, our 12 lead also shows us the size of the heart chamber, and you may find hypertrophy or a cardiomyopathy. So, cardiomyopathy means it's like a thickened heart muscle, right? And hypertrophy means it's a bigger heart muscle. A lot of the college athletes that collapse have a cardiomyopathy, but they don't know that, okay? They have started doing more 12-lead screenings of athletes. They do it with all the professional athletes, okay? They have started doing more and more of the college athletes. Italy was the first country to do this on a regular basis because they realized that there was a problem and young people were dying for no reason, okay? Because if it's identified, then they can treat it and do something about it. If it's unidentified, that's when people just collapse. And, if somebody knows CPR and they have an AED right there, maybe you live, maybe you don't. So it's always good to find things first and fix them before somebody drops dead. Okay, so somebody has right atrial enlargement, again, from chronic pulmonary disorders, so your smokers that have COPD or somebody that has lifelong asthma, okay, they can get a right atrial enlargement. And that presents with a bigger P wave. So it's higher than 2.5 millimeters in lead 2, or higher than 1.5 in V1. Okay. Does it cause any problems for them? Maybe, maybe not. In some of your 12 leads, you're going to have lead 2 run across the bottom, which actually is really helpful because that helps you figure out if there's a dysrhythmia. So like if you're looking for a block or something, you have a longer strip to look at to see if you've got PR intervals that are longer drop or the same or whatever. So it's nice when it prints out like that. But notice how the P waves here are larger. Okay, so that's somebody that's got right atrial enlargement. Left atrial enlargement. So that can be caused by hypertension or mitral or aortic valve stenosis, which happens to people as they get older. Okay, and all your bad habits, they catch up to you as you get older, right? So somebody that's had hypertension for 50 years, even if they've been on medication, sometimes they still get stenosis of the valves. Okay, This presents with your P wave longer, in lead 2. So the P wave itself, not the PR interval, okay? And then your P wave in lead V1 is predominantly negative. So, you can see that right here. Okay. So, how else can you tell if somebody has aortic stenosis? Involves your ears. Hmm?
They tell you.
They tell you, but you can also listen to heart sounds. And it's a very harsh sound. It's like, it literally sounds like fluid trying to get past something and it's running into roadblocks, okay? So I will give you something as to where you listen to heart sounds. Are we gonna do it on a regular basis? No. But you should know what normal sounds like, okay? Because then you will know what abnormal sounds like. You can also tell if somebody's got CHF, because normally we have S1, S2, those are the 2 hard sounds, so the lub-dub, right? If you got an extra one thrown in there, S3, that means they have extra fluid go out. Okay, so that's another way to kind of figure out CHF. All right, right ventricular hypertrophy, pulmonary hypertension, so that right side being more under pressure than it should be, okay? So we'll get a large R wave in V1. Your amplitude of your R wave in AVR is higher than 5 millimeters, and then discordance in V1. So let's see what that looks like. All right, so you've got taller P wave, you've got your QRS, and then you've got your T wave that's kind of upside down. And then last but not least, and this is more common, ventricular hypertrophy, hypertension or cardiac abnormalities. So you get a deep S wave in V1 and V2. Notice that you are always looking at V1. V1 is a very important lead, okay? Why is that? Well, it starts over here and kind of goes across, right? So it goes across your whole heart, so it tells you a lot about it. All right, so you've got an upside down, well, it's kind of. And then you've got, here's your deep S wave. All right. So, do we care about that so much? It's good to know, but it's not something that, oh, great, they got right ventricular, left ventricular hypertrophy, great. Okay. If they're not presenting with any kind of cardiac thing, we don't care, right? All right. But, what do we care about? What's the matter, you doing a workout?
Watching CPR is very stressful. I'm sweating.
Well, they're generating heat in that room.
It's very hot in there.
Okay.
Did they all remember to wear deodorant this time?
No.
All right, so there's a couple different things that hospitals look at when they're STEMI centers, okay? EMS to balloon time, door to balloon time, door to needle time, okay? So basically, the sooner we identify a patient that is having a STEMI or an ST elevation MI, and the faster we can get them to the hospital and to the cath lab, the better, okay? We can do things quickly, because what do we have? We have one patient, right? So our focus is on that patient. We can give them the aspirin, we can give them the nitro, we can do 2 lines, we do the 12-week, we can send it to the hospital, okay? The hospital has a 60-something bed ER, and usually those beds are all filled, right? So they need time to prepare. They need to get the cath lab team together and be ready to go. If it's at night, they're probably not there. Maybe they're required to be within a certain amount of time from the hospital, but it's maybe 15 minutes, okay? But it still takes time to get the lab up and running. If they're there and they're already doing procedures during the day, well, it'll probably be quicker, okay? But that's why it's important to know if they're not gonna take our 12 lead, that is an obvious STEMI because the patient's name's not on it, we have to make sure we put the patient's name on it, because every minute that that vessel is occluded, heart muscle is dying. And that could mean the difference between life and death. It can mean the difference between permanent disability or being able to go back to work for that patient, okay? So time is of the essence. We'll talk about occlusion MIs versus STEMIs in a little while. But we need to identify it. As I mentioned. Let's say we have a cardiac arrest. We get ROS. Great. Why do we have to do a 12 lead right away?
Figure out why they wanted to cardiac arrest.
We have to figure out if they're having a STEMI, right? Because then they're going to need to go to the cath lab emergently, right? Okay. So, some things that change during ischemia, okay? We may get a Q wave. Usually we will get a Q wave after infarction happens. So there's prominent Q waves after injury and infarction. So down here, damage is done, okay? Ischemia, here's normal, okay? Maybe we start to get some flip T waves, okay? We don't really have elevation yet, but oh, there we go. There's some elevation there. There's more, and then it resolves and it goes back to that after they're starting to recover. The Q wave is kind of like a permanent marker that, hey, they've got injury or damage. Okay? So this can all change, like I said, this can change in 10 minutes. Okay, so that's why it's important to do multiple 12 leads sometimes. Okay, so we'll look at J points and all that when they give us what you look at. So all right, give me so your T wave, we're looking at that too. We're looking to see if it's peaked, if it's symmetric, if it's broad, okay? We look at that. So this gives you a kind of a little bit of what, some of the things that we'll see. So if your patient's ischemic, you may see that T wave inversion, so it's flipped upside down, okay? Or ST segment depression. So the ST segment is below the isoelectric line. That means they have ischemia. What do you think we should do about that? Should we ignore that? Probably not. Okay. We're gonna give them aspirin? Yeah. Right? They're ischemic. Something is causing ischemia. Okay? Depending on what their pulse ox shows, if they're lower on the pulse ox, like less than 92, we want to give them a little nasal oxygen. Okay? If their pulse ox is normal, there's no need to give them oxygen, and in fact, it can hurt them. Okay? If you give somebody oxygen when they don't need it, and it creates a hyperoxia, it increases free radicals. What does free radicals do? It can cause vasoconstriction at times, right? We don't want that. That's bad. So, injury happens. We usually see a ST segment elevation, and timing, it can happen minutes after the clot or hours, okay, depending on the artery that it's in and blocking. The higher up it is, the more of the artery it's blocking, the more you're going to see the elevation. Okay. Anybody ever hear of tombstone T waves? Yes, it's called that for a reason. Okay. And then once they have the infarction, you get the Q waves. And that happens within several hours to several days after their MR. Okay, so. So the right-sided EKG, we talked about this the other day. Why? Because we want to see if the right side is involved, because it's very much involved in preload, and we don't want to make them hypovolemic. Okay. So, we move V4 over, press acquire, and then we want to make sure that we write it's right-sided on our 12 lead so the doctor knows the difference. Because we want to give our 12 leads to the hospital unless we have transmitted them. Okay? If we have sent them via triage, we should print them out and give them to them, because I don't know if they keep those if it gets attached to the patient's record. Ideally, our monitors send every time we want them to send to the hospital. But sometimes there are problems on the monitor's end, and sometimes there's problems on the receiving end at the hospital. Okay? So, now, when we're looking at elevations, things are grouped together. Okay? Let's say that you have elevations in lead 1 and lead 3, but nowhere else. That's probably not a STEMI, because they don't go next to each other. Okay? They don't follow a pattern that we're used to following. Okay? 2, 3, and AVF, that's a pattern that's together. Okay? So it's 2 consecutive leads. If they have 2 millimeters or above of elevation at their J point, then that's considered a STEMI. Okay? 1 AVL 5 and 6 we look at, right? B1, B2, B3, B4, okay, those all go together. Where do you think B7 through 9 is? Where do you put those? On the back, right? Why would we do that? Can somebody have an isolated posterior MI? Yeah, it's unlikely, but it does happen. Okay? What are you going to see on the front side of them, do you think? And their leads like B1 through 4. Depressions, yes. So if you have a patient and you're seeing depressions in like B1 through 4, you need to do that B7 through 9 on their back, because they're probably having a STEMI. And then you need to label that B7 through B9 on your printout so that the doctor can see it. Okay? Not all cardiologists, interventional cardiologists, are created equal. Some care more about their statistics than they do saving people's lives, unfortunately. Okay? So, some hospitals more than others. Unless you prove to them that, hey, this is actually a STEMI, and here's the proof, they don't want to take that patient to the cath lab. Right? So, if nobody does a V7 through V9, and you don't find the STEMI, they're not going to take them to the cath lab and just treat it as like, oh, they're having an MI, but we're just going to treat it medically, versus the intervention that they actually need. Okay. So, unfortunately, that happens. All right. So what else happens? We just talked about that. We talked about that. All right. So yes, we're going to give aspirin and nitro. What do we want a minimum blood pressure to be for nitro, systolically? About 120, right? And if it's possible that if it's inferior wall, we got to be careful. And if it's right-sided inferior wall, then we have to be super careful, right? And have our 1,000 bag hanging. All right. All right. So. Sometimes we have patients that are having an NSTEMI. What kinds of patients don't have typical symptoms? Women, right? Diabetics, older people that don't feel things the way that they used to because they have nerve damage, they have neuropathy, okay? So they may not have the crushing chest pain that like a 45-year-old male might have, okay? You show up on the scene and your typical, somebody having a heart attack, let's say it's a 45-year-old man, grabs his chest. Does anybody know what this sign is called? Levine sign, right? People do it. It's kind of wild. You're like, huh, that's Levine sign, okay? But women and diabetics and older patients may not do that. They may just be dizzy. They may just be vomiting. They may just feel super tired. okay? So that's why we fully assess our patients. Because if you do not, you are going to miss it. And if you miss it, then there's consequences for your patients. Never mind, there could be consequences for your Medicard, but there's consequences for the patient, okay? I cannot tell you how many medics will just like BLS stuff because they think it's bullshit, or they don't, you know, what am I going to do for the patient? You're going to do your job is what you're going to do, okay? So, you know, and sometimes it might not be your typical person. It may be a younger person. I had a 42-year-old female. It was myself and another female AEMT, and she reported having chest pain and just not feeling well. The chest pain was now gone, but she just didn't feel right. She just felt like super tired, okay? 12 lead didn't show anything spectacular. She was a little hypertensive, and she's like, do you really think I need to go? And she had 2 little kids. I'm like, yeah, you've got 2 little kids. Here's some aspirin, okay? She didn't have chest pain anymore, so I didn't give her nitro. We worked her up, we brought her up to the hospital. Turned out she was having an MI. She was having what they call an NSTEMI, so she didn't have ST elevation MI. But that doesn't mean you don't have damage, okay? So she was in the hospital for a couple of days, and they treated her medically. And when she got out, she stopped by the station, and my partner was there, and thanked us for saving her life. Don't know if we actually saved her life, but, you know, you've got to have that high index of suspicion. And I can tell you that like 75% of the medics I worked with would have BLS turned. Maybe even a higher percentage. Or signed her off, worse. Okay? So you've got to have that high index of suspicion. Women don't present the same. Okay? You just feel super fatigued. That is a very common sign. Okay? Or they have back pain. Or they just feel dizzy. They don't feel right. Okay? So, can we tell everything by our EKG? No, we cannot. It only catches 50% of the MIs. The other 50% is caught via blood work. Okay? The sensitive troponins that they take, that test. And it may not even show up in the first couple hours. They have to do troponins every few hours. And then use the first test, it may not show up, and then the second one, that's when it starts to rise. Okay? So we cannot rule out an MI pre-hospitally. So, you know, it drives me kind of crazy when like a medic will do, oh, I'm going to do 12 lead. Oh, it looks fine, you're good. Really? What about the other half? What about the blood work and the other things? You're going to sign that patient off? If you have enough suspicion that you're going to do 12 lead, that patient should probably go to the hospital. Makes sense, right? So, sorry, I get off. That stuff drives me up the wall. Because people do miss MIs. All right, so what do? You guys have been going to the cardiac cath lab, so you see what they do, right? It's kind of cool what they can do. They go in there, they use a balloon, and they can open up that artery. Okay? If they have multiple blockages, usually what they'll do is they'll do a coronary bypass, like if they need to bypass like 4 arteries or whatever. But usually we see the patients that are acutely having an issue, and they need to go in and open up that artery, okay, and reperfuse the heart. And like I said, we need to get them there quickly. They shoot for 90 minutes from the time of onset to getting that artery open. Okay. Obviously, well, the time they hit the door to getting that artery open. It depends on where we are. If you live more rurally, if you're in Sullivan County and you're having a STEMI, well, you're going to have to go to Garnet. That's not around the corner. Okay, because Catskill doesn't do, they don't have a cath lab. So they got to drive your butt to Garnet. So 45 minutes. So there's 45 minutes of time that artery is not open. Okay, so a lot of it depends on where you're at when it happens. Okay? If you're in an urban environment near a cath lab, then you have a better shot at having less damage. That's just kind of the way it is. There are places that fly STEMIs out in the country because they are so far away from places. All right. If patients are just having ischemia, they may not benefit from emergency PCI. Okay. But what can we do for them? Try to alleviate the ischemia. Nitroglycerin, aspirin. Okay. Aspirin is the only thing that actually shows a mortality benefit. Nitroglycerin does not. It may relieve the pain temporarily, but aspirin is the thing that prevents those platelets from clotting more. Okay, it doesn't break up the clot that is already happening, but it prevents further clots. If somebody goes to, let's say they go to Catskill Regional, what they often will do is they will give them TPA to start busting out that clot, get them in the ambulance, and send them to Garnet to have their cardiac catheterization. Okay, so that buys them some time and maybe will relieve the clot. All right, so there's some things that you also may see on the 12 lead that you may be able to pick up other things. So pulmonary embolism, acute intracranial hemorrhage, and electrolyte abnormalities. So let's see what we got here. You say anything that's concerning? So when we're talking about the J point before, the J point is where, is right here, okay, where the T wave starts, okay? It's higher over here than it should be, okay, because it should be on the isoelectric line, okay? So it's kind of higher than it should be. So that's a concern. And it's like that all the way across the board to some degree. So that would be concerning. What about the axis? Is it normal? Look at your cheat sheet. It is normal. Okay, so that's good. The rate's good. There's a P for every Q or S. Okay. Okay. There's, let's see, is it, no. Okay, so let me see. Yes, that one just like doesn't really. All right, so this is a little bit better. All right, let's look at this one. So this one, where's that J point? Look at that. All the way up there. Okay, is that good?
Mm-mm.
No, not good at all. But it's elevated pretty much in all the leads. Can that be possible? It could be. But it's generally more indicative of pericarditis than it is of an MI when you have it like all. How do people present with pericarditis? What do they say about their chest pain? Does it feel dull or does it feel sharp?
Sure.
Mm-hmm. It feels sharp and it's positional. So they bend over, it may hurt more than when they stand up. Okay. Have they been sick? Were they sick the week before? And basically, what is pericarditis? It's an inflammation of the pericardium of your heart. Okay? So usually there's an episode of some sort of illness like the week before or 2 weeks before, and it's like viral, and now it's affecting the heart. Okay? So you will see ST elevations throughout. Okay? Throughout all the leads. And their pain changes, and it's described more as sharp than it is dull. Okay? Or squeezing. Because most people if they're having an MI, they describe their pain usually as like a squeezing or a pressure, right? And that's why we don't put words in their mouth. We want them to tell us what it feels like. All right, now, pulmonary embolism. You probably don't need your 12 lead to tell you, because your patient is probably going to be super short of breath, but not always. Sometimes they may have had a syncopal episode, or they're just dizzy. Okay? But their 12 lead can show up with this pattern, S1QT3. Right? So they have an S wave here in lead 1. They've got a Q wave and an upside down T wave in lead 3. Okay? That can be indicative of a pulmonary embolism. Okay? They also may have a new right bundle branch block. So you see they have R here and R prime, so they have 2 R waves. Okay? In V1. It's a little bit of kind of like a bunny ear kind of thing going on there in 3. All right? And they've got some ST depressions going on over here, V1 to V3. Now, if you see this, it does not 100% say that they're having a PE. It could also mean right heart strain, okay? But it makes you more suspicious that it could be a PE. All right, hypothermia. You may get something called an Osborne wave. You have to know this, okay? So, see this odd appearance here? That is your Osborne wave, okay? They're usually pretty bradycardic. They may have T-wave inversion. They may have ST segment depression, but you're going to get that Osborne wave there. So anytime you're answering a question and it says they have an Osborne wave, you should immediately think hypothermia. Okay? All right. So, other important things. Hyperkalemia. See how that T-wave looks like it would really hurt if you sat on it? That's hyperkalemia. Too much potassium will kill you. Okay? Kidney failure causes hyperkalemia. So your renal patients, they had a cold and didn't feel like going to dialysis. It's really not an option for them not to go to dialysis, because dialysis removes toxins from their bloodstream, including potassium. Okay? So can they have a sudden onset of kidney failure and become hyperkalemic? Absolutely, especially if it's like accompanied by diarrhea and vomiting. Okay? So anybody that could have compromised kidneys, so long history of hypertension, maybe not care for it as well as it should, or any diabetic, you got to think about they possibly could have this. So you see these PT waves, you got to think hyperkalemia. If they start widening out, that's bad, because that's a sine wave, and then, like I said the other day, the sine wave, if you kind of keep pulling at the string, it goes to asystole. Okay. All right, hypokalemia, so they don't have enough potassium. Their T wave is kind of flat, and they may develop this guy, a U wave. Okay, so it's kind of an extra. So you're looking at it, and you've got your P, your QRS, and your T in for all your, complexes, but then you've got this guy after your T. That's your U wave. Okay, so it's hypokalemia. All right. If they have too much calcium, they may have a shortened QT interval. If they don't have enough, they could have a longer QT interval. Not something that we're generally going to see acutely. Okay. This hypertrophic cardiomyopathy, people get shortness of breath, chest pain, syncope. All right. This is what some of the younger athletes get and go into a rest for. All right. So, do we think about this? There's some weirdness going on, right? Do we have two consecutive leads with ST elevation? No. We've got V1 that has ST elevation, but not V2. V2 has a flip T wave, as does V3 and 4. Right? We've got kind of a odd P thing going on here. Right? They've got a right bundle. They've got a left axis, the junctional. There's all kinds of things going on here. So they have a hypertrophy. We're going to stop here because I think your brains are fried. Before we get into all the craziness. There's this picture also in your handouts. This is another way of looking at the different axes, okay? I like it because it's got the different coronary arteries in it. All right, the more you look at that, the better. Which one is that? It's pretty big. Okay. So that will kind of help you visualize because it has the leads in here as to what lead is looking at what part of the heart. Okay. All right. So look at your 12 lead that says ECG hyperkalemia in the middle. And it's the one that has the giant peak T waves. Oh, yeah, there it is. Says hyperkalemia on top. So sometimes it can be this obvious, okay? But you want to go through and look at it, and let's look at what's the rate on this. What do you think? Do you think it's that high? Okay, so yeah, it's about 100. Okay, but what do you notice about like lead 1, 2, 3? It's very wide, right, and bizarre looking. You can, I mean, you see bumps. So, like you see, there's a P wave, and there's kind of a QRS, and the T, what the hell is that doing? I don't know. Right? And then you go looking at the V leads, and look at those T waves. That looks like it would hurt to sit on, right? So there's your hyperkalemia. It does not look like a healthy heart, especially the leads 1, 2, and 3. But then you've got your hyperkalemia here. So this is one of those ones that you're going to monitor your patient very closely. You're going to make sure you have access because you may be giving them calcium to counteract the potassium. All right? They've got a wide QRS. It's only going to get wider. And it can happen, like you got a trip from Fishkill to Poughkeepsie, it can happen in that period of time. And you may have to break out the calcium to give them, because that will stabilize the myocardial and keep those QRS complexes from getting wider, okay? Because they will get bradycardic and end up in a sine wave, which goes to the next step is asystole. So you need to prevent that at all possible, okay? So if you have a Zoll, you're going to have to hit the 12 lead button a few times. Like every 10 minutes, do a new 12 lead, okay? And keep retaking your patient's vital signs. All right. let's look at the one that says anterior lateral AMI. It's giving you the answer. The one that says ECG anterior lateral AMI. So, is there ST elevation in some leads there? Yeah.
Yeah.
Yep. So the most prominent, it starts in kind of V2 and goes to V3, 4. Starts to come back down in 5 and 6. Okay, but it's an anterior lateral. Do you see where the J point is really high? 2 boxes above, or 2 little boxes above? Okay, so yes, they're having a STEMI.
Where are you saying the J?
Look at V2,
Yeah.
and you see where it's like a couple boxes above the isoelectric line that it starts the T wave?
Can you?
Yep.
So this is right here? Yep. And then right here? Yep.
Cut. All right, let us stop there for now. Yes, I will upload this onto Brightspace. Why don't you guys take a 15-minute break?